Hello, and welcome to Schneck Foundation's webinar focused on the topic of joint pain. I'm Laura Kirtley, President of the Schneck Foundation Board of Directors. We're fortunate to be joined today by a few of Schneck's top orthopedic surgeons who will guide us through the next hour as our audience asks questions pertaining to joint pain and treatment options. Thank you all for taking the time to join us today. Yesterday, our registered participants were emailed a video explaining the joint replacement process at Schneck. I hope that you've had the opportunity to review it and are ready to get your questions answered. However, before we begin, there are a few housekeeping items to announce. First and foremost, this webinar will be recorded and posted to Schneck's YouTube page for future viewing. And following the introduction of our physicians today, the audience can start asking questions. We ask that you use the Q&A button at the bottom of the screen and not the chat button to ask questions. For those of you who may not be familiar with Zoom webinar, if you hover around the bottom or sometimes the top of your screen, you'll be able to access the toolbar where you can submit your questions via the Q&A button. If you'd like to, you may check the box to submit your questions anonymously, but as your moderator, the questions will only be visible to me. I will read them as they come in for our panelists to respond. We'll answer as many as time allows today and then promptly at 8 p.m. So now for the introductions. Our panelists today are orthopedic surgeons specially trained in treating all bone, joint, and muscular conditions. We are grateful for your willingness to educate us and answer questions about joint pain and replacement. With us today are Dr. Paul Kevin Girth, Dr. Jill Michaels, and Dr. Chris Williams. Let's start our session with their personal introduction and their areas of practice. I will note, however, Dr. Marr may jump in here shortly, and when he does, we will allow him the opportunity to speak as well. Dr. Girth?
Good evening. So my name is Dr. Paul Kevin Girth. I go by Kevin because I always have. I grew up in Central Indiana, trained at Indiana University, and then raised a family, and my wife was from Grand Rapids, Michigan, and was in a practice there for 28 years. And for a variety of reasons, we elected to relocate our practice, and her and I came to Southern Indiana almost 6 years ago. And that was a very, very good move for us. I really enjoy this hospital. It fulfills my needs professionally and socially. And my practice has built very quickly to a nice, satisfactory level. I would say I'm a general orthopedic surgeon with the exception of spine. There are none of us in this group that do spine surgery, but as a general orthopedic surgeon, I do a wide variety of procedures. If you do the math, I've been in practice for about 34 years, and I intend to practice another 3 or 4 before finally retiring, and I certainly intend to stay here for the duration of my career. In the time that I've been here, my practice has morphed a little bit into doing a lot of upper extremity. I had a practice that mirrored Dr. Williams' practice with an emphasis on total joint replacement of the lower extremity in Michigan. But here I do a fair amount of elbow and wrist and hand procedures, as well as other types of procedures that all of us tend to share. But it's really a pleasure to work here, and I look forward to finishing my career here. Thank you.
Thank you very much, Dr. Girth. Dr. Michaels?
All right, sorry, I had to unmute. Yes, I'm Dr. Jill Michaels. I started here at Schneck in 2013. I came right out of fellowship. I did a fellowship in sports. However, I do feel like my practice is also heavily general orthopedics. I do seem to have a little bit of more emphasis in shoulders, including like rotator cuff surgeries and joint replacement, shoulder joint replacement surgery. And I am married. I have 3 children, 9, 7, and 3, and hopefully they will not bug us until after 8 o'clock.
Thank you so much. Welcome, Dr. Marr. We're glad to have you on our webinar today. We are just now introducing ourselves. Would you like to introduce yourself and your areas of practice?
Sure. So I'm Dr. Darcy Marr. I'm originally from the west coast of Canada. I did my training at the University of British Columbia in Vancouver on the west coast. I subsequently did a fellowship in Chicago, again in sports, like Dr. Michaels. I practiced for a year in Chicago, and then I came down to Seymour. I've been here for 2 years now. My practice is general orthopedics with more of an emphasis on minimally invasive shoulder and knee arthroscopic procedures. And like Dr. Michaels, I have 3 kids and a wife, and we just got a new puppy, so lots on the go.
Thank you so much. Dr. Williams?
Hi, yeah, I'm Dr. Chris Williams. I started work in Seymour back in 2009. Did most of my training in Chicago. The majority of my practice is joint replacement, but I am a general orthopedic surgeon, much like Dr. Girth, and so I do fracture care. I do some sports procedures, arthroscopies, and that kind of thing. Yeah, happy to be here and give some information to the community.
I am a small person and I'm concerned about knee replacement and the size of the replacement. How is one fitted for a replacement? Dr. Girth?
Kind of like a pair of shoes. There are a variety of sizes that are available, from very small to very large, and they essentially will fit just about every size of person available. I've never had a situation where an individual is too small for the smallest implant available or too large for the largest. And so we select, based upon some intraoperative measurements, which size most closely resembles the dimensions of the patient's knee. So again, I would say it's very analogous to a pair of shoes. Whether you're a size 9 or a 10 or 11, you will find a shoe that fits, and the same is true with the implants.
Thank you. Dr. Michaels, we have a question. I am 67. I have low vitamin D. Do you recommend creams or vitamin D vitamins, and how much?
Wow. Well, I would probably more the vitamins. I think that get better absorption, but as far as dosing, I don't really have a good insight on that. I usually defer a lot of that to the primary care physician. So unless anybody else has anything they want to add to that, sorry.
I take between 5 and 10,000 units a day is what I take.
How often can a person receive gel injections? Dr. Williams?
It's about every 6 months. So a lot of that's directed by the insurance companies. Will pay for it every 6 months. That is based on some literature as well. Yeah, your cutoff is every 6 months. So as long as it lasts 6 months, you can go ahead and repeat the series as long as it's working.
Great. Dr. Marr, how does Schneck Ortho integrate with the school system in the sports medicine program?
So Schneck has a really close connection with the sports programs in and around the high schools here. Our training staff, actually the physical therapists and ATCs, are linked right in with us, and they in general have direct access to the doctors too if they need us for any reason. Oftentimes we'll come out and be on the sidelines at games as well. So we have a direct link, and we're always available for consultation.
Great. Do I know if I need joint replacement surgery?
It's a frequently asked question, and I answer that question by asking 2 questions of the patient. Number one, is the degree of pain and disability that you're experiencing with your arthritic joint interfering with the things in life that you really enjoy and want to do? So the essence there is quality of life. And I think as orthopedic surgeons, it is our responsibility to attempt to improve one's quality of life. And so again, it gets back to, are there things you would like to do, whether it's playing with your grandchildren, golfing, hiking, bicycling, whatever your interests are that you simply can't do anymore, then that's one indication. And then a second indication is, do you have pain at rest? I think it's one thing to have, say, a sore knee, for example, after you've done some exercise, but when you sit down and rest or put ice on it or take medication, it gets better. I think that's entirely different than the person who truly has knee pain. Most of their day interferes with their sleep pattern. There's a sleep deprivation that ensues with that. And I think that takes the situation to the next level. So I think of the answers to those two questions is yes and yes. Do you have night pain, and do you have interference with your so-called activities of daily living? Those are, I think, good indications that it may be appropriate to consider knee replacement surgery.
Thank you. Dr. Michaels, I have intermittent right shoulder pain and occasionally right arm weakness upon waking as I sleep on my right side. What do you start with? Meds, physical therapy? Is an MRI done initially?
So usually I start with an x-ray and an exam. And I feel like with those two things, I can pinpoint pretty accurately what may be causing the shoulder pain. I do medications as an option, and therapy is always an option as well. I do offer injections quite often for shoulder pain, as I feel like that is a little bit quicker acting and maybe longer acting than trying to take medicine through by mouth. An MRI possibly. Unfortunately, we are in a world that is driven a lot by insurance and what they'll allow. So sometimes we have to do A, B, and C before we can get that MRI. And sometimes it's not a huge factor, but that unfortunately does play into the discussion of MRI. So,
thank you. Dr. Marr, we'll have you try to answer this question, and then if other people want to weigh in. There are some alternative treatments I've been hearing about. PRP is one of them. Do you all use that, and how exactly does that work, and what are the results you see from that?
Okay, so that's a long three-part question. The first is PRP is platelet-rich plasma. So it comes from your own blood. We take a sample in the office. So yes, we do use it for certain indications. We take a sample of your blood. We spin it down in this machine called a centrifuge, and we take just the portion we want, which is the platelet-rich portion with all the healing factors. It can be used in various conditions. So some tendinitis, it has a bit of a track record for knee arthritis as well. So there are some tight indications for it, but it can be used. What was the third part of that question?
It just went away.
So yes, we do use it. It's from your own blood.
Oh, the results. Do they get good results?
So the results in tendinopathy are fairly good around the elbow and knee. The results for knee arthritis, I believe that, the meta-analyses go back and forth between cortisone, gel, PRP, which one is superior, but all three of them can be effective in the right patient.
Thank you very much. How long does joint replacement typically last? I'm going to ask Dr. Williams.
Okay.
And then I'm going to ask others.
Right. So I think the book answer is 15 years. That's what people say. The thing is with that, the technology of putting these joint replacements in is always improving, and the materials are always improving. So with certain materials, I've heard up to 30 years for a knee and hip. And that people might disagree with that, but I think it's definitely attainable. I see that in the office. And with the advent of the robotic joint replacement, I think we're going to see them last longer, because implant longevity is closely tied to the accuracy in which that these implants are put in. And so the more accurate we can get with implantation, the longer that they should last. And so I think if you're gonna go by strictly the book, I think people will still say pretty much 15 to 20 years, but I think that we're going to see those longer implants in and perform well into the 30-year range.
Dr. Girth, your experience?
No, I agree. When I first came out of training back in 1989, there was a lot of concern that with the volume of artificial joints that were being implanted, that we would have to do a lot of revision procedures. That has not come to fruition for the reasons Chris mentioned. I think the biggest single improvement that I've seen in my career as it relates to the longevity or how long an implant lasts is the quality of the polyethylene. So polyethylene is a plastic material that comprises part of an artificial joint, and historically it's always been the weak link of the system. But the improvements in the wear characteristics of polyethylene are markedly better now than they were 25 or 30 years ago. And I think that translates into an artificial joint that lasts a long time in most individuals. And so I think if you know someone who's had an artificial joint that didn't last very long, typically the reason is something other than material characteristics. It may be that they developed an infection, or maybe it wasn't aligned correctly. And of course, there's other factors such as obesity, or perhaps things like smoke inhalation that can inhibit bone growth into the implant. So there are certainly factors that we don't have control over, but in general, they last a long time if they're done properly, and if the patient does his part as well in terms of going through the rehabilitation process and trying to adopt a healthy lifestyle.
How about you, Dr. Marr?
So yeah, more focused on the shoulder than anything, but the literature for the reverse shoulders is at least 90% survival at 10 years. And I think there's some literature coming out that 15 years is attainable for, 85, 90% of the implants without needing revision surgery.
Great, thank you so much. What steps are involved in preparing for surgery of total joint replacement? I will ask Dr. Michaels.
So obviously we first meet in the office and decide that's the next plan of action. At Schneck, I think we do an excellent job of a very thorough preoperative assessment. So that will be arranged and scheduled, where you would meet with Janet, our orthopedic nurse navigator, who kind of explains the whole process, and then kind of goes through the day of surgery. Then you also will meet with our hospitalists, who are medical physicians that would follow you along in the hospital while you're there, which is usually a pretty brief stay. But they basically just help us out in making sure that we're medically at the best medical we can be, so to hopefully avoid complications. And then yeah, basically day of surgery. And then as far as the patient, what they can do to kind of prepare for a joint replacement is obviously weight loss is great. If we and we kind of try to, we have a kind of a strict BMI of 40 is kind of our cutoff for when patient qualifies for a joint replacement as far as knee and hip. And then as far as exercise is great even before joint replacement, because the more mobile I think that joint can go into surgery, the better the outcomes will be on the back end. And then things like, quitting smoking, and then just being prepared for afterwards too, like having family members involved, being prepared to need help and being ready to ask for help, because it is, we try our best to make it as painless as possible, but it's not a pain-free procedure. So you will likely need some assistance for at least a week or two afterwards, maybe longer, depending on your state, medically and comorbidities. So.
Thank you. What, I'll ask Dr. Williams this question. What, can both knees and hips be done at the same time?
Okay, that's a good question. That's something that I get fairly frequently. So I think there's mixed opinions on this. I will go by kind of the way that I practice. There is definitely an increase of risks associated with performing bilateral joint replacement, whether that be knees or hips. Your risk of infection is higher, and your risk of blood clots is higher. We all do education, CME type stuff, and we go to these big conferences. And the last big conference I was at, they had a panel of experts from across the nation, joint replacement experts that have high volumes of joint replacements, and none of those experts performed bilateral joint replacement on a regular basis. There are some caveats to that. I think people that have bad deformity, so sometimes arthritis can get so bad that your knee will not will not extend all the way, and sometimes you get really bow-legged or knock-kneed. And I think with people with extreme deformities, sometimes it's better to go ahead and do both so that they can rehab a little bit easier. But in general, I prefer not to do both at the same time because of the increased risks and complications that are associated with that. I would say on average, if a person needs both joints replaced, on average, the time that the patient is ready to do the second one is usually about 3 months in my experience. However, I have done them much closer together if the patient is ready. If they're recovered from the first one, pain levels are under control, and they're ready for the second one, I'll do them closer. I just don't recommend doing them in the same operative setting.
Do any other surgeons do those together, or have you? Dr.
I have done bilateral knee replacement at the same time before, but I agree with all of Chris's remarks. And in fact, I do fewer of those than I did early in my career, because I do think that some of those risk factors are higher. So it's the exception and not the rule to have both done. The vast majority of patients who have two bad arthritic knees, almost always one of them is going to be at least somewhat worse than the other. And in my experience, if you replace the worst knee, even with the intention of doing the other knee at some point fairly soon, very often the knee that you've not replaced does feel better for a while, maybe a year or two, which kind of makes sense, because if you replace your worst knee to the point, and you get to the point after your rehabilitation that you're not favoring that knee, you're not limping on that side, you can actually sort of take a little stress off of the opposite knee. And again, that can feel better. So patients are often surprised at how they get some improvement in the knee that's not yet been replaced. And so I think, in my estimation, really about the only indication now for doing both is if you've got such a severe deformity in both knees that you simply cannot rehabilitate if you only do one at a time. And that's a very small percentage of patients.
I'm going to ask each of you this question. How often do you perform joint replacement surgery? And I'll let you start, Dr. Girth.
Not nearly as much as here as I did in Michigan. Chris has the lion's share of hip and knee replacement. Having said that, I personally average 2 joints a week. And the ratio between knee and hip replacement is roughly 2 to 1.
Dr. Williams?
I'm usually doing 3 to 4 a week, and I agree with 2 to 1.
And I know Dr. Michaels mostly does shoulders.
Yeah. I do a wide variety. I should look this up because I do get asked this often, but I mean, I probably do about 2 joints a week as well, but it may be a combination of a knee and a shoulder, or 2 shoulders, or occasionally a hip, but usually, yeah, a knee and shoulder.
Dr. Marr?
So I'm still ramping up my practice volume, so it's about once a quarter for me.
That's wonderful, though. What do you all see as the most frequent complication of surgery, Dr. Marr?
The most
It doesn't
frequent,
say necessarily joint replacement or minimally invasive, so
okay. I would say the most frequent complication I see is stiffness, either in the shoulder or the knee. But this can be worked through with physical therapy, and it's mostly temporary in my patient population.
anyone else? Let's see what more. Oh, will I be on pain medication in the hospital and when I am at home? I am assuming this is after surgery. I guess what it's asking is how much pain and discomfort can I expect to have?
Well, that largely depends on what surgery you're talking about. They're all highly
It doesn't
variable.
say, so let's just say for the shoulder, I hear that's really painful.
Rotator cuff repair, yeah, that can be quite uncomfortable. And usually in that scenario, you're not admitted to the hospital. You're going home the same day. Our anesthesiologists do a great job at providing patients with nerve blocks. That can either just be a single shot or stay in for up to 5 days, which can greatly decrease the amount of narcotics needed or pain medications needed at home. Generally, my patients are off in a week or 2 from a rotator cuff repair, if that's what they're asking about.
Okay, thank you very much. Dr. Girth, do you recommend, or what's cortisone versus gel injections, it says? Which one is better?
No, that's a great question. They're different from one another, and neither of them are great. Cortisone injections have a rapid onset of activity, so if they're going to help, patients will often see improvement within 48 to 72 hours. The downside to cortisone is they don't last very long. So typically you'll see that improvement fade away in a period of as little as 4 to 6 weeks. There's a lot of variability there, but in general, I tell patients following a cortisone injection that within a couple of months, they'll likely return back to their baseline pain. So I think the indications for cortisone is really not so much the management of arthritis. It's a chronic condition, not going to get better. More on the management of something that you might expect to get better, something that might be temporary. So let's say overuse tendonitis, for example, the shoulder, that is destined to improve over time. I think cortisone can make the patient feel better, or perhaps relieve their inflammatory pain more rapidly. But the utility of cortisone for at least severe arthritis is not particularly helpful, regardless, despite the fact that insurance companies often make us go through that hoop before proceeding with gel injections. Gel injections, in some respects, is even more controversial. It's been around since 1997. The first one was Synvisc, and there's several manufacturers that make competitive products which are fairly similar one to another. The products we use in our office is really based upon just whatever contract we have or what we're comfortable with using. But gel injections don't have the rapid onset of cortisone, but after typically 3 to 4 weeks, a patient may begin to see some improvement. The advantage is if they are helpful to a given patient, they can last several months. I've had patients where it can work for as long as 12 to 18 months. Although I think the average is probably more in the 6 to 9 month category. They do eventually wear off. And I think that the degree of arthritis has a bearing on how well the gel injections may or may not work. As you might expect, the more severe the arthritis, the less you can expect a response to the gel injections. And so really the indication for, I think, both cortisone and gel injections for at least arthritis is in patients who have mild to moderate disease as opposed to severe symptoms.
Thank you. Just, live webinars, just like live TV, sometimes the unexpected can happen. And Dr. Williams, we really want to thank you for your time today that you were able to spend with us. Is there anything that you would like to leave us up with before you go that maybe we didn't ask in the panelist questions, but you would like our audience to know about joint replacement?
Yeah, I mean, I think one of the things that I get a lot in the office, that people are very kind of timid or afraid sometimes of joint replacement. And this kind of brings out this webinar kind of brings out, the technology and the techniques are constantly evolving. And this is not the same kind of surgery it was back in the 70s. I mean, not only have our techniques as orthopedic surgeons improved with implants and smaller incisions and less invasive surgery and quicker recoveries, but also even anesthesia techniques have changed dramatically from the way that they used to be. And so we're doing more regional anesthesia. We don't have to use as much general medication to put people to sleep. So things are much safer. The recoveries are faster, and it's a much more pleasant experience than what it used to be. And I hear that all the time from patients that have had surgery. The next day I go in and talk to them, and most of them are pleasantly surprised at how smooth the process was, how well they were treated at our hospital, and how they feel the next day. A lot of times I'm sending people home the same day of surgery, and that's something that even when I was doing my training not too long ago, we were keeping people three to 7 days in the hospital after joint replacement, and now it's swung to where we might release oftentimes I'll release a patient the same day. So things have really changed. It's not as bad as what people make it out to be. And here at Schneck, we have excellent results, and we have extremely low complication rates. Our complication rates are lower than most of the surrounding hospitals. So we're doing things right here, and it's truly is a team approach. Our team in the ortho office, but also the nurses and the anesthesia providers, we all act as a team, and I think that has really led to very good outcomes and low complication rates for our patients. And people, like I said, people are very pleased and pleasantly surprised at how smooth the process is. So we'd love to help you out.
Thank you so much for joining us,
Thank
Dr.
you.
Williams. We have a question coming in, Dr. Girth, and actually also for Dr. Michaels and Dr. Marr. This participant wants to know if each of you do the anterior hip procedure. Dr. Girth, you want to start?
I wasn't until Chris taught me how to do it. So I have been certified in doing the anterior hip approach. I don't do a lot of those, but I do have that capability, and in the right patient, I think that's an excellent technique.
Thank you. Dr. Michaels?
Yes, I have been trained and been doing the anterior hip approach since my residency, and that's my preferred method for total hips and hemi-hip arthroplasties, where if you had a broken hip and had to have a hip replacement, I do it that way as well. So I do think that I am seeing less or little faster recovery with that, and less issues with dislocation after surgery. So I've been very pleased with that approach.
Great. Do you have anything to add, Dr. Marr?
No, I do not do the anterior approach. I do a lateral approach for partial hip replacements for hip fractures.
Okay. Thank you very much. And what is different about that then? That it's just the location of where the incision is?
Yeah, it's the location of where the incision is. The anterior approach, is touted as benefits of more of a muscle sparing approach. It does require some special certification, as Dr. Girth and Michaels have elucidated here, but it can be highly effective in the right patient, as Dr. Girth had said.
Thank you. I appreciate that. As I'm looking in the question queue, I am seeing that most of our questions have been answered tonight. I do want to ask the panelists, just as I did Dr. Williams before he had to leave. In the time that we have left, is there anything that you would like to share or to communicate to patients who are experiencing joint pain that we didn't cover in the questions from our audience? Dr. Girth, I'll let you start.
Absolutely. We haven't spent too much time talking about the non-surgical treatment of hip and knee and shoulder arthritis. And I think that patients who come to us need to understand that there are several things that we can suggest, and as a team, the physician-patient team can do to try to mitigate symptoms short of surgery. And that's entirely appropriate to do. Surgery generally is something that comes into the conversation later as opposed to sooner. So patients need to understand that there are a lot of things that we can do, whether it's medication or the injections we're speaking about, therapy, weight loss, smoking cessation. And then there's even some surgical procedures that are joint sparing that most of us have the ability to do on select patients. So that needs to be understood. The other thing I wanted to make a comment, which is a little off topic from what I just said, but I just want to really emphasize this. When I came here 6 years ago, I had a lot of options in terms of where to relocate my practice. And one of the things that attracted me to Schneck was the quality and completeness of their preoperative assessment program. Chris talked about it a little bit earlier, but we do have a group of hospitalists and internists who evaluate all of our patients prior to surgery. And patients need to know two things about that. Number one, these physicians stay in close communication with a patient's primary care physician. So even though your family doctor may not make rounds on you or see you while you're in the hospital, they are still very much aware that you're having your joint replaced, and they are kept abreast of any potential issues. So they're actually part of the team. They're kind of unseen, but they're part of the team. And secondly, the internist and their group that sees you prior to surgery to assess your preoperative status, they are the same providers who will see you after surgery if there is a complication, or let's just say that you're medically complex and we as orthopedic surgeons aren't well versed at managing necessarily hypertension or diabetes or some of these other conditions. And so they're an integral part of the team both before the surgery and afterwards. And I think that if you understand that as a patient, that should give you some degree of comfort.
Thank you. Dr. Michaels?
I don't know if I have a whole lot else to add other than I do think that we do an excellent job here. I agree with Kevin in that I'm very thankful for our preoperative assessment by the hospitalist, because I may have a patient that I think is perfectly healthy for joint replacement and come to find out that's not always the case. So thankful that they are part of our team and making sure that patient's ready. And then, and I think that does definitely speak volumes for our low complications. I mean, we really do have some of the lowest infection rates, I mean, in the country, I believe. So, and I think that hopefully, this webinar gets out, and that I think just so people can understand that they can get their joint replaced and be comfortable close to home. You know, they don't have to go to a big city when they can get great care here.
Excellent. Thank you. And Dr. Marr?
Yeah, so I'd just like to kind of piggyback on what Dr. Girth was saying. I often see patients in the clinic who have just held out and held out and held out. They've had a painful hip or painful knee for years and years and years. And by the time they get to us, there's little that we can do aside from surgery. But if that patient comes in early, if the patients come in early, if they have a painful joint, there are many modalities, non-operative modalities, that all of us will go to before surgery that could help prolong the health of that joint and limit the pain that they're experiencing. So I would just highlight to patients that we have an excellent team here, and if you have a sore joint or arm or leg, come in and see us, and we'll take care of you.
Thank you so much. Well, thank you so much to our doctors for taking the time to share your knowledge and your advice with our participants. If you'd like to make an appointment with one of these doctors or their team, you may contact Schneck Orthopedics and Sports Medicine at 812-524-3311. Offices are located in 4 counties. Currently, the main office here at Schneck Medical Center is located on the 5th floor, as well as offices at Schneck Family Care in Jennings County, Scott County, and Washington County. The office hours at the Schneck campus are Monday through Friday, 8 a.m. to 5 p.m. Walk-in hours are also offered for acute injuries, Monday through Friday, 8:30 a.m. to 11:30 a.m. These details and other information, if you didn't catch them, will be emailed to the registered participants. We hope you've enjoyed this webinar and learned about joint pain and the many options that you have with Schneck Orthopedics and Sports Medicine. Thank you for your participation. Thank you, doctors, and good night.
You're welcome. Good night.
Good night.